else. We hope that we can do something about this in the future. Our presentations are always very relevant to the times in which we live and how general practitioners are affected by these times. Let us pray. Dear Lord and Father, for this International Women's Day, we pray for peace in our communities across all nations. Where there is hatred, let us sow love. We pray for all women, especially women, but all people who face prejudice, inequality, or gender disparities. We pray for the empowerment of women on this special day and for the positive support of the men in their lives, that these women may achieve their goals. Grant us wisdom to recognize bias and a voice to speak out against it. Equip us with your strength to face the challenges when and where they occur. We ask you, Lord, to bless this webinar and all who are participating in it this evening. Bless our presenter, Dr. Aldis Buckland, and Dr. Paula Henry, who will contribute later on. Let the words of our mouths be acceptable in your sight, O Lord. Amen. It's time for us to just share a very short video from the Wonka Working Party on women and family medicine. Go ahead, Sam.
Party on Women and Family Medicine was established at the 16th International Conference of Wonka in Durban in 2001. The Working Party takes a leadership role in advocating for the concerns raised by women doctors and women's health in family medicine and general practice. The Working Party was consolidated at the 17th Wonka World Conference in Orlando in 2004. It has had successful pre-conference events at many meetings since, including the 18th Wonka World Conference in Singapore, 2007, regional meetings, and at the Wonka World Conference in Cancun in May 2010. Working Party on Women and Family Medicine has workshops and events at Wonka regional meetings, and aims to have a policy development working meeting in between each triennial Wonka World Conference. Working Party on Women and Family Medicine is a policy initiator in gender equity. Important bylaws changes and the establishment of the Wonka Organizational Equity Committee were adopted by the Wonka World Council in Cancun in 2010. Membership is open to all interested family doctors. Interested doctors are invited to contact your regional lead and attend the Working Party on Women and Family Medicine workshops at regional Wonka meetings. The vision and mission of the Wonka Working Party on Women and Family Medicine is to promote the role of women family doctors working in Wonka. We aim to highlight their special contributions and reduce the barriers they face, thereby enabling them to reach their full potential. This, in turn, enhances the contributions of family physicians and general practitioners around the world to clinical care, women's health, education, research, and leadership in family medicine. The objectives of the Wonka Working Party on Women and Family Medicine are, well, quite clear. First, to develop a communication platform within the Working Party on Women and Family Medicine and Wonka. And second, to develop a regional team in all the Wonka regions. Our regional activities are focused on a couple of key areas. First, we aim to have activities on women's health in all the regions. Second, we strive to develop mentorship programs and support women to become leaders within the regions and Wonka. When it comes to development and conferences, our goals are twofold. We aim to develop teaching and research activities within the regions. Additionally, we plan to have pre-conferences and fireplace wisdom sessions in all the regional and world conferences. Join us in shaping the future of family medicine through the Wonka Working Party for Women in Family Medicine. By becoming a member, you'll connect with a global network of passionate family doctors committed to advancing gender equity, leadership, and professional growth in our field. Membership is open to all interested family doctors. Don't miss this opportunity to make a difference. Contact your regional lead today and take part in our Wonka Working Party for Women in Family Medicine workshops at regional Wonka meetings. Together we can drive meaningful change.
Well, I hope everyone was able to appreciate something of this working group, this women's working group with Wonka, from that short video, which showed what we hope to achieve and who we are. And I ask those who are interested in joining, please to get in touch with Dr. Paula Henry or with Mrs. Lynn Hyatt here in Jamaica to register. Who passed on the information to Dr. Henry. It is now for me to speak to the presentation for this evening. Sepsis affects about 50 million people worldwide, and approximately 11 million people die of sepsis every year. Over 80% of these cases with sepsis originate in our communities in the setting of the environment around us, in the setting in which our primary care physician is going to be the first contact. And so it is especially important that we address this matter right now. Early recognition of sepsis with early intervention saves lives. So we have with us this evening Dr. Aldith Buckland, who is our presenter, and who will discuss how to manage sepsis in a GP setting. Dr. Buckland is a family physician and works in private practice in Jamaica. She's a past president of the Caribbean College of Family Physicians Jamaica chapter and the Association of General Practitioners of Jamaica. And she co-chairs the One Health Planning Committee here in Jamaica. She is the representative on the Planetary Health Alliance Caribbean hub, and she is a founding member of the Caribbean Sepsis Alliance, formed in 2024. She has received numerous awards here in Jamaica, including the World Family Doctor Day Jamaica 2024 Long Service Award for her dedicated service to family medicine, awarded by the Caribbean College of Family Physicians, the Jamaica chapter, the Association of General Practitioners of Jamaica, and the University of the West Indies Family Medicine Program. She is also the 2024 Wonka 5-Star awardee for the North American region. She's an avid gardener and homemaker, and she loves to exercise and she loves to play with her dogs, and she has 2 wonderful daughters who keep her youthful and keep her hands full and balance her at all times. So please welcome Dr. Aldith Buckland to speak with us on the management of sepsis in general practice. Thank you, Dr. Buckland.
Hi, Doc. So we're going through the process of sharing again. There you go. So we're just gonna share, and then once we bring up your PowerPoint, we should be good to go.
Okay. There we go.
Not sharing yet. It should say start broadcast.
Oh, sure. Okay.
All right, so we want to come back into Zoom. Are you in Zoom right now?
Yep.
Okay. And then on the Zoom,
Message share.
click on that.
Uh-huh.
And then you should, right, click again, share screen or start broadcast should be there.
That broadcast right there it is.
Yes. Yes, let's start. And then perfect. So now we just need to navigate to the PowerPoint. You started sharing, we can see what your screen is showing now. Great.
Let's see.
While Dr. Buckland is getting her PowerPoint up, I would like to say Happy International Women's Day to you all. However, please remember you don't need to put your emails or contact information into the chat for your CEs. Over to you, Doc. Everything's up.
Is up now?
Yes, ma'am. Perfect.
Good evening, everyone. Pleasure to be here. The topic is sepsis in the general practitioner setting. I'm Aldith Buckland, and I'm also a member of the Caribbean Sepsis and Antimicrobial Resistance Alliance. Now, this is so important because we know that AMR is one of the reasons why we have sepsis, because the bugs have got so intelligent, they know how to fight the medications that we have. All right, so sepsis awareness is very important, and this is one of the missions of the sepsis alliances around the world. So there's Global Sepsis Alliance, and just last year, we formed the Caribbean Sepsis and AMR Alliance, because all the other regions had an alliance except the Caribbean, and we said, after One Health meeting last year, we said, what, we don't have one? So guess what, we just got it started, and it is several people around the Caribbean who were part of the steering committee. And you're also welcome to join the Caribbean Sepsis and AMR Alliance. You can Google it, and then you'll see a form come up that you can join. All right, so sepsis awareness is very important because it is a silent killer. There are about 50 million cases per year, and at least 11 million persons die. And that is roughly 3 times the population of Jamaica. That's a whole lot of people. There are over 80% of cases in the communities, and you don't have to die from sepsis, you know. Some people actually do make it through. However, survivors may face lifelong consequences. And 1 in every 5 deaths worldwide is associated with sepsis. So everyone can get sepsis, and certain people are at even higher risk. So people with chronic diseases, for example, of the lung, liver, and heart, people with no spleen, people with weakened immune systems, for example, AIDS and diabetes, children under 1 year old, and adults over 60. And the persons who survive have post-sepsis symptoms. They can be emotional, they can be mental, they can be physical, have sadness, anxiety, fatigue, difficulty sleeping, difficulty swallowing, clouded thinking, difficulty concentrating, muscle weakness, poor memory. How many times you heard after COVID that person say that their brain feels foggy? However, remember this, prevention saves lives. Prevent infection, prevent sepsis, saves lives. And we can do this through vaccination, hygiene, using clean water, making sure that we wash our hands before we eat our food. We make sure that we have hygienic practices in food preparation. We want to prevent hospital-acquired infections, have safe childbirth, And yes, awareness, which is what we're about today. So what is sepsis? The lay definition of sepsis, which is the Marinoff definition penned by the Global Sepsis Alliance in 2010, states that sepsis is a life-threatening condition that arises when the body's response to an infection injures its own tissues and organs. The task force modified this definition slightly for the use by health professionals to reinforce the fact that sepsis is used to describe only those patients who have organ dysfunction. So the professional narrative definition of sepsis, which is Sepsis 3, the Sepsis 3 task force, defined it as life-threatening organ dysfunction due to dysregulated host response to an infection, clinically characterized by a change in SOFA score by greater than or equal to 2 points. Sepsis is not a bad infection, but the body's response to infection. This is helpful to us and our patients that antibiotics alone will not fix the problem. Septic shock. Septic shock is a subset of sepsis where particularly profound circulatory, cellular, and metabolic abnormalities substantially increase mortality. Clinically identified by a vasopressor requirement to maintain a mean arterial pressure of greater than or equal to 65 millimeters of mercury plus serum lactate of over 2 millimoles per liter that persists despite adequate fluid resuscitation. Now, pragmatically, as general practitioners, septic shock should be a term used in written or verbal communication to describe presumed septic shock. A patient who is hypotensive and who has a lactate of over 2 millimoles per liter following fluid resuscitation, we should not rely on the need for vasopressors to make a presumptive diagnosis of septic shock outside a critical care environment, which is the environment that we work. Now, the term severe sepsis is redundant. So we only have sepsis and septic shock. Let me give you some definitions. What is an infection? An infection is invasion of body by disease-causing organisms. Uncomplicated infection is an infection not resulting in new or worsening organ dysfunction. That is, uncomplicated infection, you have a change of SOFA score less than 2 points. There is something called NEWS2, which is a National Early Warning Score 2. It's an aggregate severity of illness score between 0 to 20 for adults with points ascribed to increasing physiological abnormalities. So the physiological abnormalities we look at are respiratory rate in NEWS2, the oximeter reading for oxygen, if you needed to get extra oxygen, we look at the systolic blood pressure, heart rate, and level of consciousness and temperature. Some of you would have heard of the SOFA score. I'm just introducing you to some terms, and we'll go through it a bit later. SOFA score is a sequential or sepsis-related organ failure score, and it goes from points 1 to 4, and it is ascribed to physiologic and biochemical abnormalities representing dysfunction of 6 organ systems, which are the organ systems are respiratory, cardiovascular, hepatic, coagulation, renal, and neurological. You may have heard of SIRS, S-I-R-S. Hello, SIRS. Systemic inflammatory response syndrome, characterized by greater than or equal to 2 criteria exceeding the thresholds for temperature, heart rate, respiratory rate, and white cell count. It was formerly used in combination with infection to identify sepsis, but now SIRS is discarded, as often it represents an appropriate host response to any inflammatory insult. All right, we're going to go through some other definitions. Severe sepsis, it's an updated terminology because I said we're only using sepsis and septic shock. So severe sepsis, wipe that out of your brain. It's an outdated terminology that combines SIRS and organ dysfunction. This is now replaced by sepsis. Sepsis is redundant. It's a meaningless term. Formerly used to describe sepsis, blood poisoning, is also redundant and meaningless term. Formerly used to describe sepsis, urosepsis, is a urinary tract infection with new organ dysfunction. It's not any type of UTI. All right, so it's a UTI with new organ dysfunction, not any type of UTI. Neutropenia sepsis is neutropenia with new infection related organ dysfunction. So this new infection is related to an organ dysfunction. Remember, sepsis is always related to organ dysfunction. Febrile neutropenia. Patient with neutropenia and a temperature of greater than or equal to 38 degrees C, which may or may not be due to infection. Pneumonia is an infection of one or both lungs caused by a pathogen. Reserve this term, reserve pneumonia, for serious lung infection rather than an uncomplicated lower respiratory tract infection. Now the term, which is very important, red flag sepsis. Now this is a very important term in the GP setting. This term is used to describe the presence of any one or more red flag criteria, as described by the UK Sepsis Trust tools. And another term is amber flag sepsis, which is a term to describe the presence of any one or more amber flag criteria, also described by UK Sepsis Trust tools. All right, so the American Academy of Family Physicians, in their volume 101, April 1, 2020, described clinical manifestations of sepsis and septic shock. The patient is looking unwell, and the manifestations would be cardiac, constitutional, dermatologic, gastrointestinal, genitourinary, musculoskeletal, neurologic, and pulmonary. What do we see in the cardiac region? Tachycardia, hypotension, warm and flushed skin because of vasodilation. We have poor capillary refill and new murmur. Constitutional. Patient presents with fevers or rigors, malaise or myalgia, diaphoresis, anorexia. What happens to this skin? There are ecchymoses or petechiae, bullous lesions, erythematous, fluctuating purulent lesions. There may be ulceration, a rash, splinter hemorrhage, or erythema. What happens in the GI system? The person may present with abdominal pain, distension, rigidity, decreased bowel sounds, diarrhea, which may be bloody or non-bloody, and emesis, that's vomiting. What happens in genitourinary? The person may present with dysuria, frequency hematuria, pyuria, low abdominal pain, costovertebral tenderness, vaginal discharge, or bleeding. And the musculoskeletal system, the person may have joint pain, joint swelling, regional muscle pain, with or without edema. They may have crepitus, saddle anesthesia, extremity weakness. Neurologic, the person may have headache, altered mental status, neck stiffness or rigidity, seizures. And in the pulmonary, the upper part, they may have sore throat, dysphagia or trismus, lower part of the lung, cough, shortness of breath, pleuritic chest pain, tachypnea, or hyperventilation. So you see, they can present in so many ways, but we just need to be mindful. We're going to use our clinical acumen. We are bright people. So could this be sepsis? If you think you have an infection and you develop any one of these symptoms, you need to go straight to the emergency department or dial for help and just ask, could it be sepsis? So this is an acronym spelling sepsis. S-E-P-S-I-S, S, slurred speech or confusion. E, extreme shivering or muscle pain. P, passing no urine in a day. Severe breathlessness. I, it feels like you're going to die. And S, your skin is mottled, discolored, or very pale. This is by the UK Sepsis Trust. Now, why I put this up here is because as GPs in the community, we do a lot of advocacy with our patients and with communities and health centers and with our association. So we can always talk about this and let the community be aware of various presentations of sepsis. All right, we need to be sepsis savvy. And we also want to involve the media, because the more people that know about sepsis, we're going to have less deaths, because then people know and then they'll present earlier to either us or the hospital. Now, any child who presents breathing fast, has a fit or convulsion, looks mottled, bluish or pale, has a rash that does not fade when you press it, is very lethargic or difficult to wake. Wake up, wake up. Kid is not waking up or feels abnormally cold to touch, might have sepsis. We want to ask this important question. Could it be sepsis? And then make the call or get yourself to the hospital or get yourself to the doctor fast. Any child under 5 who is not feeding, is vomiting repeatedly, hasn't passed urine, or the nappy has not been wet for 12 hours, might have sepsis. If you're worried they're deteriorating, guess what? They are. You want to ask, could it be sepsis? It is such a simple question, but it could save a life. Early sepsis detection saves lives and limits disabilities. This is another acronym, and this is one I like to use in the communities, TIME. T, and I actually even like to think about it when I look at somebody who's unwell. And I look for temperature, T, is it higher or lower than normal? Is it higher than 38 or lower than 36? Infection, they may have signs and symptoms of an infection. M, they may have mental decline in that they feel confused, sleepy, or difficult to arouse. And E, they're extremely ill. They have severe pain, discomfort, shortness of breath. Guess what? You remember all of those things that I mentioned, going from all the different systems? Well, that goes under the E, extremely ill. So T, temperature, infection, mental decline, and extremely ill. And you just need to ask, could this be sepsis? If it fits into that, just send the person to hospital. No. Or when you educate your community and your patients, just let them understand TIME. If they wait at home and watch this thing, and I know sometimes Jamaicans love to watch and watch and watch, they're cutting their lifetime short. They're literally cutting their lifetime. So they need to get to the hospital now, because it's like a hitman has come to knock out the organs one by one, and that hitman is not waiting. It is going to go boom, 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 boom. And no matter what you try, no matter what you do, the patient is not going to make it. So we can have some screening prompts. Let us think about this. We have a patient coming in and they present a certain way. Ask, what sort of person would present like this? What sort of person would present like this? Think about in a One Health perspective now. The person has his own host factors, all right? Then he may do work in an environment. Suppose he works in a market and there was a rain and storm and so on, and rat urine and everything, and all this splash on him. You want to bring all of this, or he went and bought something from the market, like a guinea, and he never washed it and started to eat, and then he just became ill. And people in the family thinking, what is happening with him? Once you see something happening to somebody who behave differently, you want to get that person to hospital fast, all right? It could be sepsis. So you want to think, what sort of person would present like this? In patients, should we start looking for sepsis? In which patients should we really start looking for sepsis? Screen for sepsis or suspected sepsis and record, patient has sepsis, yes or no, and decide. But how are you going to decide? We're going to look at the risk factors for sepsis. We're going to use your clinical acumen. Think sepsis if the patient looks unwell. We're going to have a set of criteria which indicate potential acute illness or deterioration, or the person is failing to improve as expected, and in which context of infection should prompt a health professional to actively look for organ dysfunction. And then you may have concerns of the patients or their advocates if they can't speak for themselves, or other colleagues, or their family, or other carers. She's not normally like this, I've never seen him look so unwell. Now, all of those are screening prompts that something is going on. That's not right. Now, you ever heard or read of QSOFA? QSOFA was proposed as a screening prompt by the Sepsis 3 Task Force to aid in identification of patients with infection who have a high risk of death. And SOFA is an acronym for sequential or sepsis-related organ failure or assessment. Now, a Q-SOFA was positive if a patient had 2 or more of the following. The respiratory rate was 22 per minute or greater, that altered mentation, the Glasgow Coma score less than 15, and the systolic blood pressure was 100 millimeters of mercury or less. But guess what? In 2021, the most recent surviving sepsis campaign, academic guidelines strongly recommend against the use of Q-SOFA as a screening prompt for sepsis, particularly in systems using track and trigger scoring systems such as the NEWS 2. Q-SOFA, why? Because Q-SOFA was found to have low sensitivity and missed early sepsis cases. So we have another way of getting around this. And when you think sepsis, normally we think of infection and bad vitals and organ dysfunction. Remember I told you about SIRS? Remember I told you about this old-time sepsis criteria, which was SIRS plus suspected or present source of infection? But that old-time sepsis criteria never had? Yes, you're right. It never had organ dysfunction. So guess what? They scrapped that. And they scrapped severe sepsis as well, because now everything is sepsis. But I'll just read it to you. Because how they used to define severe sepsis was organ dysfunction, hypotension, hypoperfusion, and that's, you can pick that up by lactic acidosis if the systolic blood pressure is less than 90, or the systolic blood pressure drop was greater than or equal to 40 millimeters of mercury of normal. And another way to know that there is something happening with the circulatory system is your prolonged capillary refill time. You know, that is so important. You know, all you do is hold the person's finger at the heart level, and you're just going to squeeze on the end of the finger, just hold it, and it would latch, and then let go. Look at it, look at your finger right now. You're pressing it hard, and then let go, and you see the blood come back. If the blood came back quickly, guess what? You're normal. If it doesn't come back quickly, something is off with the perfusion. So, screening prompts. Going to look at the risk factors. Risk factors are the people who are very young, older people, or frail people, persons who have impaired immune systems because of illness or drugs. We're going to look at women. They may be prenatal, natal, or postnatal, and we're going to look at the neonates. All right. So the very young are those who are under 1, and the older people are over 75. This is by the UK Sepsis Trust, or people who are very frail. Impaired immune systems because of illness or drugs, including people treated for cancer with chemotherapy, people who have impaired immune function, for example, with diabetes, a splenectomy, sickle cell disease, people taking long-term steroids, people taking immunosuppressant drugs to treat non-malignant disorders such as rheumatoid arthritis, people who have had surgery or other invasive procedures in the past 6 weeks, people with any breach of skin integrity, for example, cuts, burns, blisters, or skin infections. You know, a rose thorn could just stick you, you know, and that could bring you into sepsis. Just any breach of your skin. People who misuse drugs intravenously, people with indwelling lines or catheters. Now, the women, I said they could be prenatal, natal, or postnatal. So if the women are pregnant, they've given birth, or they had a termination of pregnancy, or they had a miscarriage in the past 6 weeks, they're in a high-risk group for sepsis. In particular, women in this group who have impaired immune systems because of illness or drugs, they have gestational diabetes or other comorbidities, they have needed invasive procedures. For example, they got a section, they had forceps delivery, there was removal of retained products of conception, they had a prolonged rupture of membranes, they have or have been in close contact with people with group A strep infection or, for example, scarlet fever, or they've had continued vaginal bleeding or an offensive vaginal discharge. For the neonates, the risk factors would include invasive group B strep infection in a previous baby, a maternal group B strep colonization, bacteriuria, or infection in the current pregnancy. If there was premature rupture of membranes for this neonate, if there was preterm birth following spontaneous labor, that is before 37 weeks of gestation, if there is suspected or confirmed rupture of membranes for more than 18 hours in a preterm birth, if there was intrapartum fever higher than 38 degrees or confirmed or suspected chorioamnionitis, if there was parenteral antibiotic treatment given to the woman for confirmed or suspected invasive bacterial infection at any time during labor or in the 24-hour period before and after the birth, this does not refer to intrapartum antibiotic prophylaxis, okay? And suspected or confirmed infection in another baby in the case of multiple pregnancy. I know we went through a lot, but guess what? This is going to make it very, very simple. Did you know that the UK Sepsis Trust made a GP bundle? This is a set of tools that will make our history taking and our decision making easier. And you can always Google this, red flag sepsis, or just Google GP bundle for sepsis, okay? So we start this chart if the patient looks unwell. So the person comes in, the person is looking unwell, or the physiology is abnormal, all right? So what are the risk factors? We mentioned some before, and they have it listed here. The risk factors for sepsis include impaired immunity, for example, diabetes, steroids, or chemotherapy, recent trauma, surgery, or invasive procedure, or there were indwelling lines, the IV, and broken skin, right? And then, so we had the risk factors, and we may have ticked off, and then we want to say, could this be due to an infection? Remember, the person is looking unwell, right? So we look at the risk factors first, and we want to think, could this be due to an infection? So likely source, could it be respiratory? Could it be a breast abscess, urine, abdominal pain and distension? Was there infected cesarean or perineal wound, chorioamnionitis, endometritis? But they get the drift. They're guiding you in your thoughts. Person looks unwell, and you look at the risk factors. Then you want to think, could this be an infection? And you think of the likely source. And if you say no, sepsis unlikely, then you're going to consider other diagnoses. But if you said yes, you're going to look for red flags. And the red flags would be objective evidence of new or altered mental status, systolic blood pressure less than or equal to 90 millimeters of mercury, or if there's a drop of more than 40 millimeters of mercury from their normal. If the heart rate is more than 130 per minute, if the respiratory rate is more than or equal to 25 per minute, if there's a new need for oxygen, that is, they need 40% or more to keep their SpO2 over 92%, or if they have a breathing issue like COPD, then we have to keep it over 88%. Did you see a non-blanching rash? Did the skin look mottled, ashen, or cyanotic? They hadn't passed any urine in 18 hours. And it's going to be, they say, less than 0.5 ml per kilogram per hour if they've been catheterized. So if you have any of these are to us red flags. Now, all of this, this GP sheet is just one sheet. For this presentation, I just cut it so it could fit on my slide. All right, so this is just continuation down the same sheet. So let me go back here a little. Remember, the person looked unwell, we looked at the risk factors, and then we looked for a likely source of infection, and we went to look at the red flags. And if we said yes, and if we said no, all right? So if we said no, then we're going to look at amber flags. The amber flags would be acute deterioration in functional ability. They're not doing what they used to do. The family report mental status change. So the person may say, oh, you know, grandma has Alzheimer's, or does she have sepsis? So the family report mental status change, respiratory rate 20 to 24, heart rate 100 to 130, or is there a new dysrhythmia? Systolic blood pressure 91 to 100, has had invasive procedures in the last 6 weeks. The temperature is less than 36. The person has diabetes or impaired immunity. The person is a close contact with another who has group A strep. There's prolonged rupture of membranes, offensive vaginal discharge, not passed urine in 12 to 18 hours, and there's a wound infection. Remember, we went through all of these things before, but we're putting it in a sheet form, all right? Easy. And if there are any amber signs present, you just need to go through anything clicking, then you're going to use your clinical judgment to determine whether the patient can be managed in the community setting. And if treating in the community, you want to consider a planned second assessment. When are you going to examine the person again? And you want to take off bloods, or do you? Well, you have to make, that is your choice. You want to make your best opinion, but always, always just remember to protect the patient. And then we also want to give specific safety netting advice. What are specific safety netting advice? Because if you've given it an amber thing and then you're thinking, oh, the person doesn't have to go to hospital, you're going to have to tell the patient or the patient's family what to watch out for if the person is deteriorating. So you can say, if the person is worsening, get to the hospital. That's one thing. Call me, whatever. See here? If these are the red flags on the right-hand side or the side, you notice any slurred speech or confusion, there's extreme shivering or muscle pain, person not passing any urine, there is severe breathlessness, I feel I might die. So the person is progressing, skin mottled, ashen blue or pale. So if you have no amber flags, you're going to use routine care, and the safety netting message would be to call, and you give the number to call if the condition changes or deteriorates. And you signpost to what you mean by getting worse. And I said that you can spell out the acronym sepsis, all right? Just make sure they understand what you're saying. Otherwise, just send them to hospital. You don't joke with it. If you even give them an amber and you're not with me around, just send them off. The GP red flag bundle, you want to dial whatever your emergency number is. You want to adapt, you can adapt the thing, you know, because this is the UK's business, right? And you're going to arrange how you're going to transfer this patient. So if you are the doctor and you know that the transit time is going to take more than an hour and you have IV antibiotics, you can start with a broad spectrum IV antibiotic. Make sure though that you have ensured communication of the red flag sepsis to the crew. All you have to say, and this is what we'd have to do in Jamaica, we'd have to let people be aware of what we mean by red flag sepsis. You see, in the UK, they rolled it out. They have a National Health Service and they roll out this as their plan of dealing with sepsis. So for GPs, what they said, GPs use this, all right? So ensure communication of red flag sepsis, or you could say, could this be sepsis or sepsis? You can just say sepsis to the crew. And then you advise the crew to pre-alert as red flag sepsis, which means this is danger. Where possible, you make sure that you have a written handover, including your observations and antibiotic allergies. All right, so we went through that GP bundle where we saw the risk factors, we saw the infection, and then we decided if the person was having any risk factors that would be linked to red flag, any symptoms that would be linked to amber flag, and we made our decision, all right? Now, while the person is with you, I know that you would have taken, because you're a bright person, you would have taken the vital signs. I'm sure you'd have done the respiratory rate. I'm sure you'd have done, let me go through here. I am sure you would have used your pulse oximeter. I am sure you'd have noted if the person is breathing air or if you have to give the person oxygen. I'm sure you'd have noted the person's blood pressure. I'm sure you'd have noted the pulse. I'm sure you'd have noted the person's consciousness and temperature. Let me go back now. Remember, this is one sheet, so that's why I did it like this. So the new score, this is the National Early Warning Score. It identifies unwell patients from all causes. You don't have to have sepsis, just that you are unwell. You write down the person's name, date of birth, right? And then you put the date and the time. And so you, in time 0, you record what you get, going from the top of your list, going down to the bottom of the list, as I showed you. And you, all right, where was your respiration? If your respiration is in the red zone, you know that's red flag. If, see how they color coded it for you? If your respiration was 18 to 20, so that's white, that's normal. If it was 21 to 24, that's amber, right? So it's there. So you want to go through your thing and just log what you find at a certain time. And then at another time, you're going to just log beside it where the person is. You just do that. So this new tool, remember, it identifies unwell patients from all causes. It performs well in people with sepsis. It performs well in time-dependent infection. So because you are going to see, you're going to see right in front of your eyes if they're in the red or the amber or if they're okay. So it is triggering a response from you. It is tracking what you are doing and triggering your response for action. So the Royal College of Physicians in 2017 did this, and they said, if the patient, once the patient is screened for sepsis in the context of presumed or confirmed infection, if your NEWS2 score is 5 and above, and the person looks unwell to the clinician or to the carer, and the person has had recent chemo or immunotherapy, and their lactate is 2 millimoles per liter or more, then you know that this person, you want to screen them for sepsis because they will be actually going into the red. So I showed you the GP bundle. That's told you about the risk factors and if the person had infection and so on. I went through the NEWS score that you are doing your history and examination, you're recording, and you can just log it so that this tool can alert you where the person is falling in the red, the amber, or the white. If the person is red flagged by you, you want to use a sepsis screening tool. So this is a pre-hospital, and guess what? GPs, we are pre-hospital, right? And this is for people who are 16 and over. So we're going to start this chart. Start this chart if sepsis is suspected. Factors prompting screening for sepsis would include, number 1, NEWS2 has triggered this. There's a carer or relative concern. The person has recent chemo or risk of neutropenia. The patient looks unwell. There's evidence of organ dysfunction, that is, the lactate is over 2 millimoles per liter. And the assessment that you get gives clinical cause for concern. And then you want to consider any advance directive or care planning carefully. You want to discuss this with the patient and the patient's family. And if you tick all of this and you answered yes, then you want to calculate the NEWS2 score using the latest vital signs. You risk assess and always interpret the vital signs and NEWS2 in context of the patient's medications, medical history, and response to treatment. So that NEWS2, where you actually know logging so that you can track the patient, is very helpful. And you know, this NEWS2 form is you copy it when you are actually writing the referral letter, and you send that, because this is useful to the hospital, because they're going to see the patient's progress. All right, so if the NEWS 2 score is 7 and above, you want to know this. Is the NEWS 2 score 7 and above? Or is the NEWS 2 score 5 or 6? All right, so if anyone NEWS 2 parameter with a score of 3, and they had mottled or ashen skin, non-blanching rash, cyanosis of the skin, lips, or tongue, patient looks extremely unwell, patient is actively deteriorating, risk of neutropenia. You see, all of this is happening. You're going to flag it, and you start. This is the pre-hospital bundle. And this is going to happen really if your NEWS 2 score is 7 and above. You're going to flag that red flag sepsis. If you're in the amber zone is 5 or 6. Anyone NEWS 2 parameter with a score of 3, you could have had a score of 3, but the person also had mottled skin, non-blanching rash, cyanosis of the skin, and blah, blah, blah. Patient looked extremely unwell. Patient is actively deteriorating, risk of neutropenia. If you flag that, you want to not send the person home. You want to keep the patient, further assess and review. Or, nicer thing to do is transfer to a designated destination, communicate potential risk of sepsis at your handover. You can recalculate your NEWS 2 at least while the patient is with you every 30 minutes, and you can escalate to red flag if appropriate. If you don't get any amber flags and sepsis is unlikely, you just do routine care, and you just think of some other diagnosis. And then you can have a safety net and signpost as what you would normally do. If you're deteriorating, get in touch with me. Or if you can't get through, you just get to the hospital. So in the pre-hospital sepsis bundle, resuscitation and treatment, oxygen to maintain saturations of over 94%. And if the person has a respiratory problem like COPD, you want to target for 88%. You can give 250 ml boluses of sodium chloride. That's a max that they give, 250 mils. If they're normotensive, and you can give 2,000 mils max if they're hypotensive. All right, so resuscitation, you want to give oxygen, you want to give some fluids. You want to consider if they're normotensive or hypotensive and the amount of fluid you're giving. Consider IV antibiotics. If your transit time is going to be more than an hour. Communication is king. You're going to pick your phone up and pre-alert the receiving hospital. And you're going to divert to the emergency department pronto, or any other agreed destination that is appropriate for this patient's care, and hand over that the person has red flag sepsis. In Jamaica, they're not understanding red flag sepsis, so just say, yes, person has sepsis, okay? Just put that in your notes. Let them sort it out in a hospital. Now, common infections precipitating sepsis. Pneumonia, 50% of cases. UTI, urinary tract, 20%. Abdomen, 15%. Skin, soft, bone, and joint, 10%. Endocarditis, 1%. Device-related infection, 1%. Meningitis, 1%. And others, 2%. This is in the UK. So, remember, the sepsis definition talked about organ dysfunction. So sepsis requires that the patient has one or more failing or dysfunctional organs. So there are two routes to identify a failing organ. One is a change in the SOFA score, and the other one is a high-risk criteria updated by the NICE guidelines in 2024, also known as red flag sepsis criteria. And I just done it with you. So 2 routes to identify a failing organ: changing SOFA score or the criteria for red flag sepsis, all right? And remember, this is updated stuff, as the latest one is 2024. Now look at the SOFA thing. We think as GPs, we're going to use SOFA. Look what it has. PaO2, FiO2. I don't do that. I don't do mean arterial pressure. Look at the cardiovascular system. I don't do any dopamine business. No. Yes, I could do some blood tests and so on. So issues for the GPs is this. SOFA requires reliance on blood tests, which are not yet back at time of first assessment of the patient. And sometimes there is a delay to get back the results, okay? And we, as I said, we don't do PaO2 or FiO2. And how do you measure mean arterial pressure in our practices? What does a dose of norepinephrine of greater than 0.1 microgram per kilogram per minute mean to you as a GP? This definition was created by, guess what? To be used in a critical care department by the critical care specialists. We are not in that department. So guess what? Let's get pragmatic. We're going to use red flag sepsis. That is what we're going to use to determine organ deterioration. So there are two clear inflection points for mortality in use two. The aggregate score of 7 or higher. Now, if you get, this score of 7 or higher is associated with a higher mortality than those people who score 5 or 6. And if the person scores 4 or below, they will have a lower mortality than those who score 5 or 6. The red flag sepsis criteria are designed to empower health professionals like us to initiate the delivery of sepsis 6, which has included as its first step consultation with a senior decision maker to identify other conditions which may mimic sepsis. Guess what? You know what that tells you? Refer. The first step is consultation. You're just going to refer. Don't hold the patient back because the person needs a team behind them in order to live. And by your little self, you're not a team. You're part of a team, and your role as a team member for this patient is to refer if you pick up red flag sepsis. Therefore, diagnose red flag sepsis and refer what? Later? No, refer promptly and communicate with the senior doctor at the A&E department, all right? And you can send a copy of the news too. They should prompt delivery of all elements of the sepsis 6 in 1 hour. You just start the ball rolling, get the person off. So sepsis is a medical emergency. Could this be sepsis? Early sepsis recognition and timely intervention saves lives. It is a relay race. We've got to get out of the blocks fast. Awareness and timely action. The persons in the community need to be aware. We need to engage the media as general practitioners. Oh, well, this is the job of the Sepsis Alliances. We are actually working through the media. But as GPs in your own community, you can talk, right? And so the community and the patient need to be aware. They need to be sepsis savvy. And they can come to primary care or they can go to hospital. Repetitive training for everyone on sepsis, just like on MI. You got to recognize it and act fast to save this person's life and reduce disability. Enhancing quality improvement of patient care with suspected sepsis by GPs is what we can do. So, early sepsis detection saves lives and limits disabilities. I always love this one. I always love this one because I can use this with my patients. I can use this in the community, whatever teaching I'm doing. I say, look for your temperature. Is it higher or lower? Is there any signs of symptoms of infection? Has there been mental decline? Confused, sleepy, difficulty arose? And this is, does the person look extremely ill, in severe pain, discomfort, or shortness of breath? This is your safety net. Ask, could this be sepsis? Go or refer to the hospital. No. We want to make sure that we do not cut the person's lifetime. Tell them, do not go back home to pick up your clothes. Go straight to the hospital No. I want to acknowledge Global Sepsis Alliance, Caribbean Sepsis and Antimicrobial Alliance. I've learned a lot being in these alliances. Also the Caribbean College of Family Physicians, because that's how I got into these alliances. And the American Academy of Family Physicians, from whom I had taken one of the slides, and the UK Sepsis Trust, which translated the 2024 NICE guidelines update, the NG51, into tools for use across the healthcare system. I hope that what I said today will help you to help your patients, help your community, and as part of a team that we can practice early sepsis recognition and get the patients off quickly. And remember that we want to contact the hospital quickly. So we're going to have poll questions. Sam, you want to bring up the poll?
While the poll is being mounted, we'd just like to thank Dr. Buckland for a very comprehensive and detailed review of sepsis in general practice. We have learned so much this evening, Dr. Buckland, and we just are very, very appreciative. We've learned about the GP red flag bundle, along with the amber flag, and the need to perhaps download these forms from the UK sepsis site, trust site. Please go ahead and complete the poll. Dr. Buckland will soon start a discussion based on the results of the pre and post polls.
Okay,
But we
polls
just
are
like
up
to,
now. We have 2 minutes remaining on the poll.
yes. So Dr. Buckland, people also, I'm going to ask them to put your questions in the Q&A at this time, just in case they have anything you'd like to be cleared up. I will have one question later on. Thank you, Dr. Buckland.
Thank you.
All right, excellent presentation, Doc. We're just giving about 30 more seconds for the polls, and then I'll share the results with you. All right, 10 seconds remaining. Some 60% of the participants have done the poll. 5 seconds remaining. All right, poll is complete. Thanks to everyone who participated. You should now be seeing the results, Doc, for each question.
Yeah, you can hear me, right?
Yes.
All right, so I've seen poll 2. So
Right.
should I start with that?
Sure. So the first question, could this be sepsis if a patient did not take prescribed antibiotics immediately following prostate biopsy and now has a high fever, is shivering, has extreme muscle pain, and feels like he's going to die? 95% of persons said yes.
I know these people are bright, you know. I know these people are so bright. You know, this is how one of my patients had it presented. He had not taken his antibiotic and he just done a prostate biopsy, and he ended up at Andrews in the emergency department. He said he felt like he was dying. Next one. You can read it.
The next one. Okay, the next one, number 2, for a child under 5. Could this be sepsis if he is not feeding, vomiting repeatedly, and has not passed urine or wet nappy for 12 hours? 91% said yes.
That's right. We want to always ask, could this be sepsis? You see, you don't have anything, you know, but you don't have all the facts. But you know that this kid is really, really unwell. And you want to have this in your mind, could this be sepsis? Because you want to decide between, if I make this decision and the person really has sepsis and I delay, the person is dead. Right? So you have to decide, in favor of the worst one.
Mm-hmm.
Because these are all red flags for kids who are under 5. The UK Sepsis Trust has a sepsis manual, and I just suggest that you Google it and look at it. All right, and then they have other they have the GP bundle and the pre-hospital bundle and the news too. But we'd have to, if we're going to use it, whichever region you are in the Caribbean or the world, you want to just adjust it to your own setting. All right.
Sure. The next question. Go ahead.
Would you like us to share the first poll as well?
No, just let's finish off this one here. Yes,
Okay.
you're going to do it. Let's see the third question on this poll too.
Third question on poll 2. Could this be sepsis if a child is breathing fast, has a fit or convulsion, looks mottled, blush or pale, has a rash that does not fade when you press it, is very lethargic or difficult to wake, feels abnormally cold to the touch? 98% said yes.
Very good. And you know why it's important to do this training? Because guess what? Any of us could have a kid or a grandkid, and go to the hospital, and we feel very assured to know that people who are aware and know what they're doing will pick up that this could well be sepsis. All right, it's very important. By asking, could this be sepsis? Trigger prompt action by community health teams at GP clinics, health centers, hospital A&E departments, and wards. Yes, the answer is definitely yes. Whoever is answering no, I think they're just pulling my toe. You're pulling my big toe. Let's do the first poll.
Okay, no problem. The first poll, let me stop sharing this one. And the results from the first poll. True or false? Sepsis is used to describe only those persons who have organ dysfunction in response to an infection. This was very close. 59% said true, 41% said false.
Okay, so sepsis definition has organ dysfunction, because what you have is a chain reaction where the immune system gets so dysregulated that it starts bumping off the organs. Remember COVID? If your SpO2 reached 93%, it was a big red alert, and the person's organs would start being knocked off. And no matter what they did in critical care, the person wasn't coming back. They were dead. So, and that was signaling that there's organ dysfunction. So yes, sepsis is always used when there is organ dysfunction.
Mm-hmm.
And how you define organ dysfunction for us as GPs is a red flag sepsis. All right. Sepsis is a bad infection. Is that true? No. Sepsis is not a bad infection, because it must be with organ dysfunction. Sepsis is the body's response to an infection. Yes, quite right, because it's not the infection. You can have an infection and don't get sick. You bounce back because your host response is fine. But if your host response is such that you're going to have a cascade of wicked things happening that starts bumping off your organs, it's your body's response to the infection. So sepsis is the body's response to an infection. It's not the infection. Sepsis is not the infection. Sepsis is the body's response to an infection that causes organs to crash. Next question. Next one.
Let me pull it. I believe we're at number 4 now.
Antibiotics alone can fix sepsis.
Right, and most persons, 80% said false.
That's right. We need many other things. So antibiotics is very important.
Mm-hmm.
Early intervention is very important. Fluids is, you got to also have the senior person on. Okay, so it is several things going on, because antibiotics alone can fix sepsis. That is false. Early recognition of suspected sepsis and timely intervention saves lives. Yeah. Oh, I tell you, no, there's somebody pulling my toe. All right, this one here. Sepsis, like a myocardial infarction, is a medical emergency and requires prompt action. So guess what? If you have an MI that doesn't call for prompt action, my friend who answered false. Congratulations to all those who answered true. It is an emergency. Well done, everybody. I think you've done really, really well. And read the UK Sepsis Trust manual. Google it. All right. So I give you homework. You know, in preparation of this, I just reviewed all the literature all around the world. And I said, this is ridiculous. What are we doing in GPs? And then I came across this and I said, you know what? The UK Sepsis Trust is spot on. This is exactly what we need for our GP practice, because we are not in the critical care area. We are here. And we have our role to recognize sepsis, be aware of it, and get whoever we identify off to the hospital quickly.
Thank you so much, Dr. Buckland. I don't think we could have spent a better evening as a GP, as family physicians, as we have this evening, learning more about sepsis in general practice, and also this red flag bungle means of actually checking ourselves that what we think is happening is actually happening. No hesitation, head for the hospital. Thank you very, very much this evening for your presentation. And at this time, we would like to just welcome Dr. Paula Henry, who is going to come on board here now. She is the Caribbean lead for the Wonka Working Party on Women and Family Medicine. And she will give the vote of thanks and make closing remarks. I'd just like also to thank everybody who has just wished us all happy International Women's Day. Dr. Henry, over to you.
Okay, thank you very much, Anna, for that very warm welcome. I would like to welcome everybody. Please, I have my panelist team here, these wonderful women, all international community who have joined us here today to be a part of this experience. So I'll give people an opportunity to turn on their videos. I would give a vote of thanks. Yes, but however, I want to recognize each and every woman here. Some of us are missing. So I will give a little talk, not long, and then what I would do is I would say something like, I would like to introduce the head of the Young Doctors Movement, and then the person who's a young doctor would unmute their mic and then introduce themselves and give their name and say, what post they hold. So before we go on, I realized that Dr. Anna did not give any time for questions. I guess that's because everything was so clear with Dr. Buckland, and all the answers everybody got between 98 and 99%. So it means that we all understood everything.
Actually, Dr. Paula, there do seem to be two questions. Sam, could you address them for me? Please go ahead. I'm sorry to just cut back, but let Dr. Buckland take her questions.
Yeah, I think we should do the questions.
We just go back over. My apologies, Dr. Buckland.
No problem. Thank you. Good night. Dr. Buckland, this person is asking if you could please remind us of the new definition of sepsis. And does this definition apply to all age groups, including neonates? This is from Dr. Reynolds. I need to unmute.
So the definition of sepsis, you have an infection that has caused a host response that is such that it causes organ dysfunction.
Thank you. And I think the second part of the question is that for all ages, including neonates.
Yes.
Perfect. Thank you.
The pediatric group has their definition, but it is.
Wonderful. And then
Criteria.
Dr. Henry is asking, could a clinician also use POP score or PEWES to assess sepsis in pediatric patients?
Of course, because you remember this is pediatric early warning score. So this is all coming from the same group. So we have pediatricians would have theirs. The maternal people would have MEO. They have their own maternal early obstetric warning scores. They have different ones for different specialties. So yeah, but this is the one for the GPs.
I had one question, Dr. Buckland, this for you, which was to just describe a little bit more about the relevance of this lactate level that you referred to more than once in sepsis.
Right. So whenever the immune system is doing its assault on the different the metabolic system and the organs, there is going to be generation of lactic acid in the system. And as the organs deteriorate, as a person gets more and more unwell, the lactate levels actually increase. When the lactate levels actually go higher than 2, equal to 2, you know that the person is getting worse. If the lactate levels are 4, you know they're really bad. If you find that the lactate levels are reducing, you know the person is improving.
Thank you.
So it's a trend. And also I would suggest, because as GPs, worsening of, because it's an indication of perfusion as well, right? Lactate. For GPs, we can do capillary fill.
Mm-hmm.
So do this, hold it at the person's level of the heart and look at your own, right? And lift up your finger. You see how it pinks up so fast? Now, the person who is advancing in sepsis, their perfusion is very poor, so it's not going to pink up that quickly. And so you could actually see how you're, when you're resuscitating and you're giving IV fluids, you can see if it's improving. So you should notice as a person gets better, that when you do the capillary fill, that it improves over time when the person is getting better. But if the person is worsening, it's going to get worse. So that is a lactate thing. Lactate will increase in lactate, increase in worsening of the condition. So once it's over 2, that's a problem. And this too, if you're blanche and it's not, and you're not getting your proper capillary fill quickly, the person is in problem.
That's fine. Okay. Thank you so much, Dr. Aldis Buckland. Sam, are there any other questions? Let me not.
No more questions.
Okay, thank you. Then we can go back to Dr. Henry now.
Okay, thank you so much. And I would ask people again to put on their unmute, or at least unmute when it's time to introduce yourself and open your videos. So first of all, before I say thanks and introduce anyone, I would like to let people know, most people know who I am, but I am the lead for the Working Party for Women and Family Medicine for this great continent of North America. And we have Canadians, people from the United States, and from all countries in the Caribbean. And 1 year ago, we did not have any members on this team, and now we have close to 80 vibrant women who are working together to give quality healthcare to so many persons in our region. So I would like to acknowledge every one of you, not just our leaders. Of course, I would like to say a special thanks to Dr. Buckland, who gave us what I will call a whirlwind presentation. There was so much to remember, so much to take home. I am thankful for those questions that help indeed to clarify things. But what I can say is, just remember the words red flag sepsis. And thank goodness we are all good GPs, all good family physicians who know how to take vitals. So once we take the vitals and we get those numbers, it will help to clarify where we are in terms of that spectrum for sepsis. And I would also like to say, thank goodness for those screening tools, because then we could check boxes and that would also help us to know exactly where we are, right, in the whole system. We don't have to totally remember it all. So please, thank you for that, Dr. Buckland, for that whirlwind presentation. And now we're not going to miss any patient with sepsis. We're going to get them very early. And of course, I would like to thank Dr. Anna Brown Morgan, who's usually a very terrific hostess, a moderator for these sessions. She's a pro now. But I would like to spend a few minutes and introduce this. Well, today's International Women's Day, so we have this leadership team of women behind the scenes. We have three categories. I have the executive that meet exactly with the global other members from the other 7 regions in the world. That's the executive team. I will introduce the executive team first. Then I will introduce the regional leaders, that is the leaders of Canada, the US and the Caribbean. And then I would introduce the country leads. Okay, so when I say this, you will then open your mic and then introduce yourself. Okay, so the first person I would like to introduce is our young doctor lead. Please open your mic. Let's see you introduce yourself.
Hi, good night, everyone. Well, it's nighttime here. My name is Brune Dorset, and I'm coming to you from Nassau, the Bahamas. I'm currently serving as the chair of Wonka Polaris, which is the North America's chapters of Wonka's Young Doctors Movement. Happy International Women's Day to everyone, and it's just fabulous to share the space with you women tonight. Thank you.
Okay. And today I am missing my communication lead, Dr. Maria Bianchi. She was on call for the last 24 hours, so she's not able to be with us right now. But I still recognize her. She is on the executive with me, Dr. Dorset, and we report to the global other 7 regions. Now I would like to introduce my regional leads. So I will start, I'm going alphabetically, so you all do not feel that I have any favorites. Okay, so I will start off by introducing my Canadian lead.
Okay, thank you very much, Dr. Henry. So I'm Samina Shah. I'm a life member of Wonka. I became life member many years ago. I moved to Canada about 7 years ago and continued again became member of Wonka, but now I'm representing Canada. And interestingly enough, I'm the only one in Canada at the moment. We did have some other members, but they have now retired and we are looking for more people to join us. I am a rural family physician. I don't know how it works in other countries, but Canada is a big component of rural medicine. And so I work in a small town on an island. So it can get pretty hectic with hospital work, long-term care, and family medicine clinics. And this was a great webinar. This was the first one that I've attended, and it was a great learning experience. And it's lovely to see that there were so many participants. So thank you very much, Dr. Henry, for that.
Thank you, Dr. Shah. Now I would like to introduce the regional lead from the United States.
Hi, everyone. My name is Dr. Kim Yu. I'm so excited to be greeting you here from Hawaii. And so you can see the beautiful blue sky behind me. And I came all this way to show you Waikiki Beach right here in the background, because on International Women's Day, I am celebrating well-being here on the islands and just enjoying listening to Dr. Buckland's talk on sepsis and hoping that nobody that I encounter has any issues with that. I work for the American Board of Family Medicine for Prime Registry as their strategic consultant. And I also work for a community health center, an FQHC in Orange County, California, called Korean Community Services. And we take care of multiple different Asian populations, as well as many patients who are from Ukraine and Russia, and Farsi speaking patients as well as patients who have behavioral health and are on opioid use disorder medications. We also have a center that is in a shelter, a homeless shelter as well. So lots of different patient populations that we care for in our community health center. And it's been a pleasure to work with Paula and many others on our Wonka Women's Party Wonka's Working Party for Women in Family Medicine, North America region, and just truly excited to hopefully see everyone at a regional meeting or maybe even at World Wonka in Lisbon later on this year. Take care, everyone, and hope to see you soon.
Thank you very much, Dr. Yu. Now I would like to recognize the Caribbean lead.
Hello, good evening, everyone. Happy International Women's Day to all our female attendees. I am Tamika Daniels Williamson from the beautiful country of Guyana, and I'm the Caribbean lead. It's a pleasure being a part of this esteemed group. I've been a member for about 3 or 4 years, but as of 2024, I was appointed as the Caribbean lead. And since then, I was able to convince 4 of my fellow Guyanese to join. And I hope that persons who are on here from the Caribbean, Trinidad, Barbados, wherever you're from, that you feel encouraged and welcome to join our team. So thank you very much.
Thank you very much, Dr. Daniels Williamson. So now I'm going to introduce the country leads, and I'm going to start alphabetically with Antigua Barbuda, who is Dr. Alethea Stevens. Unfortunately, she just got called out to the emergency room, so we will have to not see her today. But we're going to go right on to our Barbados lead.
Hi, good night, everyone. I am Dr. Anisha Gibbons. I am the lead for Barbados. It was a pleasure being in this meeting. It was really good to spend International Women's Day with this group of ladies. I joined the Women's Working Party for Women in Family Medicine last year, and it has been a rewarding experience. I work in family medicine here in Barbados in private practice, as well as in the hospital, because I also practice occupational medicine as well. So it has been a pleasure, and I wish you all a good night. I'm looking forward to growing our Barbados arm some more as we really get some work going in the new year. Thank you.
Thank you, Dr. Gibbons. Thank you very much. Okay, and now I would like to introduce the lead from the BVI, the British Virgin Islands.
Good night, everyone. I am Dr. Amber Wheatley. I am the BVI lead and also hoping to get more people to join my little group. I'm a family physician and I work on one of what we call the sister islands. So it's a primary care / emergency care center with a special interest in rural and remote medicine. And yeah, I really enjoyed the webinar. It's a very pertinent topic, and happy International Women's Day to everyone.
Thank you, Dr. Wheatley. So good to see you. And now we're going to go on to the island of Curacao.
Hi everyone, I'm Dorothy Younger. I'm from Curacao. Like Dr. Paula already said. Yes, I've been joining the Wonka since 2007. This is a long way ago. Have been to many of the Wonka conferences, and I'm still working now as a family physician in Curacao and also in our sister island Bonaire. And so in the last minute, I would like to wish you all also a very nice Women's Day. I hope you enjoyed it and make a good day. Make the day finish very good today, all right? Okay, bye.
So thank you, Dr. Janga. So what Dorothy didn't tell you was that we met in Seoul and she asked me to take over the lead for the working party. And I was warned by the leadership of Wonka that I'd better do a good job because I would be stepping into her shoes and she has really big shoes. So I just have to give you guys that backstory, right? With Dr. Bianca. Okay, so thank you so much, Dorothy.
Yes.
Now I would like
Welcome,
to
Paula.
introduce, thank you. So now I would like to introduce the lead for Guyana.
Good evening, everyone. I am Anisha Moore Thorne, bringing you greetings from the beautiful country of Guyana. And I am the country lead for Guyana. I am a family medicine specialist working in one of the health centers in the rural parts of Guyana. It's a pleasure being with this group, and I look forward to growing my group in this part of the world. So thank you very much, Dr. Henry, and thank you very much, Dr. Daniels Williamson, for all you have been doing. Blessings, everyone, and happy International Women's Day to all my female colleagues.
Thank you very much, Dr. Moore Thorne. So now present with us, last but not least, our powerful dynamite speaker, Dr. Alden Buckland, who represents our country lead for Jamaica.
Hello, I'm Aldith Buckland. I joined the Working Party last year, I think September, and Paul had asked me if I would be the Jamaica lead. So I thought about it and I said, okay, can do that. And I'm so glad that we have such a vibrant group because, you know, the Caribbean College of Family Physicians and the Association of General Practitioners of Jamaica, those are two strong organizations. So any of you from Jamaica who want to be a part of the Working Party, just contact me, or you can contact the CCFP office in Jamaica, and they'll get the message to me. Just need to leave your name, your number, and your email. And I think we do have something in the, as we're closing this webinar, that you can also express your interest. Thank you.
Thank you very much. And I would also like to recognize those doctors who had to work at this time or because we are into the season of Ramadan. So those practicing the faith could not be here with us because they had to be in prayer this time. So, and another person was traveling. So I would like to recognize our lead from the Bahamas, Dr. Andrea Culmo. I would like to recognize our lead from St. Vincent, Dr. Miriam Sheridan. I would like to recognize our lead from Trinidad and Tobago, Dr. Sasha Faria. I also told you that our lead from Antigua Barbuda, who is Dr. Alethea Stevens, she was just called out to the emergency room. Also, we have a very dynamic IT team that will help you put on your webinars just in case you need that type of help. And our lead is Dr. Faria Ali, who is not here today because she's celebrating with her faith. So, and of course, I can't leave without thanking our dynamic CCFP backbone administrators and team. And I want to mention especially Lynn, who is always so helpful, ready to answer our questions and ready to support us. So thank you, everybody. And we have, if there are other members, because we have 400 and something people on this call, if you want to join the Working Party, I think there's an option to do so in the Google link that is posted at the end of this chat. Also, I think you can find me anywhere. phenry_tt@yahoo.com. Should really put my email in the chat. And yes, so I think I would like to hand over now to Dr. Anna Brown to close the session.
Well, we've had such a wonderful evening, and then we've had our social, which has been wonderful, where we have seen the faces of our membership all across the Caribbean and elsewhere in the Americas. And so it's been a social evening as well as an evening full of significant learning. I'd just like to thank our panelists. I'd like to thank our presenter, Dr. Aldith Buckland. I'd like to thank Sam and Lynn, who's already done that. And I just wanted to just say, it's just been I just feel full. Thank you all for being here. Paula, thank you for being the person you are, bringing that warmth and that person, that in-house person to us. Good night, everyone.
Good night, Anna. Thank you, and thank you, Aldith.
Good night.
Thank you, everyone. Okay.
Thank you, everyone.
Have a
Bye-bye.
good rest of the weekend.
Good night.
Bye.
Bye.
The Wonka Working Party on Women and Family Medicine was established at the 16th International Conference of Wonka in Durban in 2001. The Working Party takes a leadership role in advocating for the concerns raised by women doctors and women's health in family medicine and general practice. The Working Party was consolidated at the 17th Wonka World Conference in Orlando in 2004. It has had successful pre-conference events at many meetings since, including the 18th Wonka World Conference in Singapore, 2007, regional meetings, and at the Wonka World Conference in Cancun in May 2010. Working Party on Women and Family Medicine has workshops and events at Wonka regional meetings and aims to have a policy development working meeting in between each triennial Wonka World Conference. Working Party on Women and Family Medicine is a policy initiator in gender equity. Important bylaws changes and the establishment of the Wonka Organizational Equity Committee were adopted by the Wonka World Council in Cancun in 2010. Membership is open to all interested family doctors. Interested doctors are invited to contact your regional lead and attend the Working Party on Women and Family Medicine workshops at regional Wonka meetings. The vision and mission of the Wonka Working Party on Women and Family Medicine is to promote the role of women family doctors working in Wonka. We aim to highlight their special contributions and reduce the barriers they face, thereby enabling them to reach their full potential. This, in turn, enhances the contributions of family physicians and general practitioners around the world to clinical care, women's health, education, research, and leadership in family medicine. The objectives of the Wonka Working Party on Women and Family Medicine are, well, quite clear. First, to develop a communication platform within the Working Party on Women and Family Medicine and Wonka. And second, to develop a regional team in all the Wonka regions. Our regional activities are focused on a couple of key areas. First, we aim to have activities on women's health in all the regions. Second, we strive to develop mentorship programs and support women to become leaders within the regions and Wonka. When it comes to development and conferences, our goals are twofold. We aim to develop teaching and research activities within the regions. Additionally, we plan to have pre-conferences and fireplace wisdom sessions in all the regional and world conferences. Join us in shaping the future of family medicine through the Wonka Working Party for Women in Family Medicine. By becoming a member, you'll connect with a global network of passionate family doctors committed to advancing gender equity, leadership, and professional growth in our field. Membership is open to all interested family doctors. Don't miss this opportunity to make a difference. Contact your regional lead today and take part in our Wonka Working Party for Women in Family Medicine workshops at regional Wonka meetings. Together we can drive